Hello and welcome to the topic Myelodysplastic Syndromes in the Haematology module. By the end of this topic, you should be able to define myelodysplastic syndromes, explain the pathophysiology and risk factors associated with myelodysplastic syndromes, outline the classification of myelodysplastic syndromes, describe the clinical manifestations of myelodysplastic syndromes, outline the investigations and staging, as well as discuss the principles of management. Let's get started. Myelodysplastic syndromes, or MDS, is a group of clonal stem cell disorder in which malfunctioning pluripotent cells result in hypercellularity and dysplasia of the bone marrow. This ultimately leads to ineffective hematopoiesis, which then results in cytopenia in one or more cell lines. It is observed that MDS is a disease of the elderly and has a tendency to transform into acute myeloid leukemia. In 40 to 70% of patients who develop MDS, chromosomal abnormalities are found. This percentage is higher, about 90% in patients with secondary MDS. The most common chromosomal abnormalities are the deletion of chromosome 5, 7, 11, 12, 13, and 20. This suggests a role of tumor suppressor genes located on these chromosomes. The majority of cases occur in primary MDS, but MDS can also develop secondary to chemotherapy or radiotherapy as part of a treatment regimen. The development of MDS is believed to be multifactorial. Accumulation of risk factors and genetic alterations lead to the development of a neoplastic multipotent hematopoietic stem cell. This neoplastic stem cell gives rise to defective intermediate cells that are prone to apoptosis, leading to cell death in the bone marrow. Hence, to compensate, there is increased hematopoiesis. However, despite the numbers, these cells are inherently defective and unable to mature and function. Proliferation of progenitor cells also pick up. Eventually, these patients present with peripheral cytopenias despite a hypercellular marrow. The WHO classification of primary MDS distinguishes between 6 types of MDS. This is based on the number of dysplastic cells, their lineage, and the percentage of blasts found in the bone marrow, among other variables. MDS with multilineage dysplasia is the most common type. MDS with single lineage dysplasia, MDS with ring sideroblasts, MDS with excess blasts, MDS with isolated DEL5Q, which is rare, and MDS unclassifiable, very rare. So WHO's clinical classification of MDS is based on if the cause of MDS is primary or secondary. So primary MDS comprises 90% of cases and seen most commonly in elderly patients. The exact etiology is unknown, though it is likely to spontaneously mutate. Secondary MDS makes up the remaining 10%, and it's due to exogenous bone marrow damage. Factors that result in bone marrow damage include chemotherapeutic agents, benzene, radiotherapy, radioiodine therapy or ionizing radiation, and paroxysmal nocturnal hemoglobinuria. Up to 20% of patients are asymptomatic. Depending on the affected cell line, presentation may vary. Erythrocytopenia is seen in the majority. Up to 70% of cases will present with symptoms of anemia. Patients with leukocytopenia will be predisposed to bacterial infections, especially skin infections. Thrombocytopenia will impair hemostasis and coagulation, leading to petechial bleeding. Hepatosplenomegaly is a possible finding when extramedullary hematopoiesis is exaggerated. Symptoms of MDS tend to reflect the cell lines effect and hence include pallor, fatigue, weakness, which reflects anemia, fever, cough, and dysuria reflecting neutropenia and severe infections, bruising, nosebleeds, and mucosal bleeding, which reflects thrombocytopenia. Abdominal pain or swelling or early satiety due to hepatic or splenic involvement is common. Signs of cytopenias may be evident as petechia or ecchymosis, epistaxis, and gum bleeding suggesting severe thrombocytopenia. Hemoptysis, hematuria, and bloody stools are also a possible finding. Pallor of the skin and mucosal membranes, tachycardia, or signs of congestive heart failure may be clinical manifestations of severe anemia. Splenomegaly are often found in patients with chronic myelomonocytic leukemia, indicating an overlap syndrome with MDS. This has to be differentiated from chronic myelogenous leukemia, and do keep in mind that in patients with splenomegaly, major complications include spontaneous rupture and intra-abdominal exsanguination. Fever and infections are most likely due to MDS-associated neutropenias. Now let's take a look at the approach to investigate this condition. Diagnosis is largely based on medical history, and clinical features such as B symptoms and lymph node involvement, and confirmation is based on lymph node biopsy. On morphological examination, there may be nucleated RBCs, which is the picture on the left shown by the red arrows, Howell-Jolly bodies, the picture on the right with black arrows, and pseudo-Felger-Huyd anomaly, which is the picture on the right with the blue arrow. A bone marrow aspiration with iron stain will display either single or multi-lineage dysplasia with less than 20% of blast in the bone marrow. This allows the confirmation of diagnosis as well as differentiation of subtypes and hence prognosticate the disease. Prussian blue iron staining of the bone marrow can demonstrate ringed sideroblasts, which are abnormal precursor cells with granules around the nucleus. A bone marrow core biopsy will demonstrate a hypercellular marrow, although rarely the marrow may be hypocellular. This may be repeated to assess transformation into AML and persistence of abnormalities. Bone marrow cytogenetic analysis can demonstrate chromosomal abnormalities, some of which are characteristic of MDS, such as chromosome deletion 5q31, monosomy 7, 11q23, deletion 17p, deletion 20q, and abnormal 12p. There are several risk classification systems that have been used to estimate prognosis in patients with MDS. The revised WHO prognostic scoring system is generally the most widely accepted system worldwide. Unlike other prognostic scoring that predict outcome based on presentation at diagnosis, the WPS provides prognostic information at any point throughout the course of the disease. Based on the variables listed in the table, they are each allocated a score. The cumulative score will then correlate to the relative risk as seen in the yellow box. In some patients, MDS runs an indolent course. The rest develop significant cytopenias resulting in complications such as bleeding and infections, two of which account for the most mortality related to MDS. In the remaining patients, MDS takes a turn into developing it into the acute form of leukemia, most often into acute myelogenous leukemia or AML. Outcome and median survival is highly dependent on the number of risk factors. Patients in the highest group have a median overall survival of 10 months. Patients in the lowest group have a median overall survival of roughly 8 years. The therapeutic approach is dependent on the patient's condition and takes into account their presentation, age, and comorbidities. Younger, healthier patients are more tolerant to aggressive therapy. Mild cytopenia warrant a watch-and-wait approach. Severe cytopenia will require supportive and medical treatment. The mainstay of supportive therapy is red blood cells and platelet transfusions as needed, depending on the cell counts. Vitamin B6 and B12 are given to compensate for high cell turnover rate. In symptomatic cases of anemia with low erythropoietin levels, synthetic EPO can be administered. If the patient is neutropenic, granulocyte colony stimulating factor or GCSF is given to prevent neutropenic fevers. Antibiotics are also given in infections or even prophylactically. In the medical aspect of therapy, chemotherapy is initiated if myeloblasts are elevated and there is possibility of transformation to acute myeloid leukemia. Common drugs used to treat MDS include azacitidine, which is a pyrimidine nucleoside analog, decitabine, also a pyrimidine nucleoside analog, lenalidomide, which is a drug of choice in patients with 5q deletion and is capable of reducing red blood cell transfusion requirements. An allogenic stem cell transplant is the only curative option and is only indicated in patients of less than 55 years with late-stage MDS. Let's recap. Myelodysplastic syndrome is a group of hematological malignancy involving defective pluripotent stem cells that lead to hypercellularity and dysplasia of the bone marrow. This in turn leads to cytopenias of one or more cell lines. MDS is clinically classified into primary, where the cause is unclear, or secondary, where MDS develops after exposure to risk factors, for example, chemotherapy, hence the development of treatment-related MDS. Clinical manifestation may vary and mostly reflect the cell lines affected in the patient. Diagnosis is confirmed by blood test, bone marrow analysis, and genetic or chromosomal analysis. Treatment includes medical therapy and supportive therapy, though the only approach with curative intent would be an allogenic stem cell transplant. Prognosis is highly affected by staging, and median overall survival can range from months to years. We have come to the end of this topic. Thank you.